So our final speaker is Professor Emma McBryde. And Professor McBryde, when I initially invited her, she was at James Cook University, which is her primary affiliation, and she subsequently just moved down here to University of Queensland Centre for Clinical Research. So I was surprised when she was in the foyer, but that's because she's now working here as of last week. So I hope you didn't change jobs just because of this talk. But
I didn't know you did enough.
But Emma's, I've heard Emma speak, and she's really good at explaining complex, what are likely very complex topics to a lay audience like myself. And I heard her speaking during COVID on, I was on ABC, listening to ABC on the way to work, and who's this? Came in late to our interview, and someone was making a lot of sense and was being very clear, speaking very clearly about modelling, and it ended up being Emma. So she does have a gift in that area, and as well as being an infectious disease physician, she's also done a PhD in mathematical modelling, as you do, through QUT, and also as a master in biostats, and she's very impressive. So thanks, Emma. We look forward to your talk.
Thank you very much for inviting me. Yes, it's a great pleasure to have moved across to UQ. I've just started up a position as of 2.5 weeks ago. I'll just adjust a few things here. And I know it's getting late, right? So I'm aware of that. We've had an incredible couple of speakers who've just, absolutely wowed us. And I know you're probably extremely exhausted. So I'm going to try and tell this as a bit more of a story than as anything where you have to pay attention to detail. You're seeing all the slides to start with, so that's fine. You know what's coming. If you see any maths, you're allowed to close your eyes. That's fine. I really just want to take you on a bit of a journey. All right, so I'm an infectious diseases modeller. So what I want to do is sort of talk to you about, I really like infectious diseases mathematical models that are simple and modular, because what you can do is once they're calibrated and so forth, you can apply them to different circumstances, investigate what-if scenarios and such forth, right? And then I also really like geospatial models, which I've been using more recently because they're very visually interesting. They're a great way of showing data. Heat maps are very impactful and so on. My interests are very much in infectious diseases modelling, and in more recent times in geospatial modelling, which is a very different beast, and I'll try and talk you through that a little bit, where things are very complicated. There's lots of interactions. There's a lot of granular detail about place and space and interactions. And so they're quite different. And so, but they each have their, their value. So what I'm going to talk to you today about is taking these two different types of modelling and trying to sort of join them together. And so I'm going to give you some examples of where I think geospatial modelling has been really useful, and then talk about how I've tried to, over the years, project mathematical models onto geospatial models. So let's go. The details in this talk are not important. I think it's mainly the overall themes. All right, so here I'll start with who I need to acknowledge for doing all of this work, and also, to be fair, introducing me to the whole concepts of geospatial modelling and some geostatistical modelling as well. So that's Debebi Shueno, who is a PhD student of mine pre-COVID, Kefialu Addis-Alain, who is a PhD student at ANU under Archie Clements, and I was a co-advisor. Abdul Kudos, who's was a PhD student during COVID, but worked on tuberculosis, and Samson and Alec, who are postdocs in my lab. Okay, so here are the reasons why I think we should apply geospatial models to tuberculosis. So the first is visualization. So it's a really nice way of looking at disease by mapping it. The second is to try and gain some insights into the risks associated with TB spread. So different geolocations have different features, and they can be used to assess what features cause risk of disease, and that can be applied to tuberculosis as well as other diseases, and that includes things like population density and socioeconomic conditions. Then I think the 3, 4, and 5 is where it gets a bit more interesting, and that's where you have inference, where you can use geolocation to sort of assess maybe missing cases or predict epidemiology based on current and future trends, and finally putting it all together with public health action. So to start with, I'm just going to show you some results that you're not meant to look at, which is the work that my PhD student did to just look at the landscape of TB modelling, geospatial modelling, that is. And what he found when he looked is that there are, a growing number of studies, and that they have utilised every geospatial method you can imagine that are used for other diseases have been applied to tuberculosis. So I guess no surprises there. It's an active area of research. The other thing he found was that many of the different epidemiological considerations, such as outcomes, barriers to care, you can see them all listed here, have also been used and applied to the geospatial methods. What isn't in here is any studies that actually use the combination of infectious diseases mechanistic models with geospatial models, and that's what I want to talk about today. All right, so because I'm a modeler, this is what I'm really interested in, which is the disease state mechanistic models of tuberculosis. And you've probably all heard of the SIR model because of COVID and stuff, where you start susceptible, then you move into infected class, and then you move into recovered class. And when infecteds and susceptibles get together, that's when disease transmission occurs, right? So this is like one of those, only a bit more complicated because it's tuberculosis and it's a bit more complicated. So it has susceptible, latent, which can be broken into two bits because there's the early latent and the late latent groups. And then the rest down here is all active disease. So you have some health systems components to this model where you can have active undiagnosed disease and then make your way through the health system, either being missed, which happens, or having the strain misdiagnosed. So in other words, you may get diagnosed with tuberculosis, but it's unrecognised that it has drug resistance, for example. And then you can be correctly diagnosed on the correct regimen or not. And then you can further divide this into different strains and different risk groups, such as HIV, not HIV, different age groups, and so forth. So there are interesting and important components to this. The first one is this flow here, which is the flow of incident active tuberculosis. The second flow here is the flow of diagnosis, so people going from undiagnosed to diagnosed. And so that's what we usually use to correlate to notification of tuberculosis, which is basically the main thing that's collected as data from WHO. And then there's this whole group, which is the prevalent tuberculosis. So it includes every compartment of prevalent active tuberculosis. And we, as many of you probably know, that requires a prevalence survey to understand that better, and they don't happen every day. They're very expensive, but most countries have got around to doing at least one by now for tuberculosis. And then, of course, there's the outcomes, like are people cured? Do they fail and have to be retreated, or do they die? Are they lost to follow-up, and so on? All right, so I guess what I'm trying to say is these are all very important components to the disease. It's a complex system. And so far, most of the geospatial models that are in existence only look at one of these at a time, which is fine, and they're very useful. But what I'm going to do at the end is try and draw you into the idea that you can look at more than one of these at a time. All right. So the first study I'm going to show you is done by Kefialu, who looked just at the outcome as the feature of interest. So he looked at tuberculosis outcomes and did it by district in Ethiopia, and found that TB outcomes were poorest in these red areas around the margins and best in these blue areas in the centre of Ethiopia. And he hypothesised a few reasons why that might be the case. But what he also found was that most of the explanation was not so much a kind of a clustering and an overt geospatial effect, but something to do with the features of that geography. So the wealth index, the knowledge about tuberculosis and temperature, he looked at those, and he said once they were included in this model, the actual spatial correlations kind of fell away. Okay? but that's fine. But, again, so as you can see, very pictorially, very interesting. You can see it very clearly what's going on in the country in terms of outcomes for TB. And I think that would be a very useful public health message for public health decision makers. All right. Similarly, DeBeebe looked at notifications of tuberculosis and found that there was certainly clustered, there was an effect of clustering. And he looked at other components, including that were features of each of these areas, these kabele in Sheker zone in Ethiopia. And he looked at, so for example, he found that adjacent kabele definitely had an effect. But then he also found that health centres had a positive correlation with notifications, the presence of a health centre in that region. And so that made us think, of course, that that's not what's driving tuberculosis. We have to look a little bit more carefully and cleverly at this model. So we need to look at separately incidence and notification and develop a new model that takes these things into account. So this model, which is the next paper of DeBeebe, sort of says, okay, there's incident tuberculosis and we have predictors for that. And they're things like, the size of the population, that's the offset, the, potentially bits of elements of poverty or overcrowding, those sorts of covariates. And then there's a separate bit in the model which says, incident TB may be notified, and it may be notified more if you have a health centre or other covariates that are to do with having good health coverage. All right, so what this study found, which was kind of interesting, was that case detection, so it sort of estimated all of these things simultaneously, even though you couldn't see the incident cases. There were factors associated with the incident cases. What we could see, the actual observations, were notified cases, and there were factors associated with notified cases. And what played out was that case detection rate in kabeles with no health facility was substantially lower than case detection rate in kabeles with health facilities. And that's not surprising, of course. And that changed somewhat the interpretation of the other factors, such as population density, spatial correlation, and temporal lag, which were all already there, but they needed to be there in the context of these other factors. And you can see how important that is when you look at just these two kabele here, where this one in particular looks like a cold spot when you're just looking at notifications, but it's a hot spot when you're looking at incidents as estimated by the model. So it is an indicative that we may be missing quite a few cases there, right? Okay, so I've got through number 1, 2, and 3 up to inference. So the next thing is epidemiological prediction. And so in order to do that, you really need to start bringing in a mechanistic model, all right? Let's have a look at this particular mechanistic model, which goes on to have active tuberculosis like before, treatment or no treatment, death survival in those two groups, and tries to estimate, and the aim is to estimate factors associated with each of these flows in turn. And that work has been applied by Chitwood et al. To Brazil, and also we're in the process of applying that to Bangladesh. I think I said that last time I spoke and said it would be imminent, but it's still imminent. So take this as just a work in progress, this particular work. The idea is, a bit like last time, is to try and draw out the different ways in which people transition through TB states. So there's incident TB, then there's notifications, and then within the treatment program we are able to measure deaths for those who are not treated and who go missing. We have to assume something about their deaths, and we assume that it's sort of something like historical pre-treatment death rates, for example. And we have to put priors on that and so forth. So the idea being that we can then look at different factors that impact this pathway in different places, and so we can assess what those factors are and whether they actually make any difference, such as the number of healthcare facilities, having some impact on case detection. A number of prisons or a poverty index might have a factor on incidence and so forth. All right, and the aim of this sort of work is to be able to, at the end, saying, well, look, this is the overall fraction treated, and find vulnerable places where people are not treated. Okay, so finally, to my last study that I want to discuss, and this is my attempt at really bringing the two things together: the infectious diseases, mechanistic models, and geospatial models. So back to Sheker Zone in Ethiopia. So we knew that we had hotspots and cold spots for disease incidence. And what we decided to do was try to have a meta population model. So each of the spots had their own, if you like, TB epidemic going on in those spots, and they also communicated with each other. So there was some, coupling between the two. All right. Now, we had to reduce all of this rich data set down to 3 patches. So you got your hotspot, you got your medium adjacent region, and then you got your more remote regions. All right. So just down to 3 patches. And the reason for that is that we then used the data on notifications and incidents to parameterize this model. So we have fitted to the data 4 different parameters, one for each of the hotspot, which is how much transmission there was in each of the hotspots, and one for coupling. And that's how likely you are to get TB from an adjacent region versus your own region. And so that coupling matrix had one parameter, as you can see here, which is rho, and we had to fit those 4 parameters, which is hard enough to do when the only data that you have is notification data by year. All right, but having done that, having actually said, okay, we fitted this and we know that the hotspots have a certain transmission rate per person per year, and the adjacent and cold spots have a much lower transmission rate per person per year. This is where it gets exciting as far as I'm concerned, because this is where you can say, well, what if you improved case detection in those hotspots compared with improving case detection in the cold spots? Surely it's going to make a lot more impact. Certainly in the hotspots it is. Is it also going to impact the cold spots because there's this coupling and so forth? So then you can look at, optimizing public health interventions. So how do you optimize public health interventions under these circumstances? And what we looked at was a hotspot targeted intervention versus universal coverage. A universal coverage obviously is ideal, but when you have a limited funding envelope, maybe targeted coverage is a good idea to start with. So what happens is, if you just go for the hotspots, you make good headway. You have a steep coverage curve, but it plateaus, right? You, for example, impact on incidence here. Things look really good for a while, but the reach is limited. You can do more with less, but you can't do as much good. So it makes sense. So, and this is the same thing said in a different way, which is depending on your investment budget envelope, the proportion that you spend on hotspots will change. So low is good in this graph. So if you have not much money, you should spend all your money on hotspots. But once you get a certain amount of money, you're better off spending it in more universally, and that sort of makes sense. All right, so I guess the idea is that mapping is really great. It is very visual. It allows for things like risk assessment and inferring missing cases. In order to then take that the next step and look at epidemiological prediction and public health action, it's, in my view, really good to tie it to a mechanistic model of disease, but they are very data intense to actually parameterize properly. So that's a struggle. So the opportunities and challenges in the future: data availability is improving in many countries. It's also so huge in some areas that it really has to be curated and managed. But the sort of data I'm talking about in step 1 is things like vital registry data, which is just like so necessary before you can even do anything in tuberculosis, and doesn't exist in many of the countries that we really know where the missing cases are in tuberculosis. Obviously, processing power for this massive generated data is improving. I think decision makers are becoming more aware of modelling in the era of post-COVID, its strengths and weaknesses, which is good. And there's a lot of aligned methodologies using that are, I guess, generously developing methods that we can borrow as well in areas such as forecasting, geostatistics, health economics, machine learning, and so forth. So, thank you very much. Sorry about the false start. All right, cheers.
Thanks very much. So, did the Ethiopian ministry use any of that data?
It was certainly presented to them by both Kefyalu and by Debebe. He very presented more locally, so he was in this checker zone. Whether they, I'm not certain that. I mean, it was presented to them, and they were. It was discussed that they're aware of where the hotspots are now. They're aware of where the potential missing cases are. I can't tell you that they've built 1,000 different health centres and things like that, which would have been nice to be able to tell you that's absolutely true.
That slide, though, that if you invest in certain amounts of money, what's the bang for your buck you get?
Yeah.
I think that's sort of quite helpful, isn't it? To help guide us even at a rough level.
Yeah, absolutely. I mean, I do, this is different, but I do quite a bit of work with Global Fund where they are actually the funders, and they have said, to countries, you can't just spend without thinking about what the best value for money spend is, and we come along and try and provide advice as to what, if you had another $1 million to invest, would you invest it in active case finding, or would you invest it in chasing down latent TB or managing HIV? Like, which ones of these would be the best in which sets?
So good. This is a model that you derive. Say, for example, in Vietnam, they looked at latent TB, active case finding. Would you be able to sort of take some of those sort of studies and, I don't know, superimpose or
absolutely. So that's what I think is like the real beauty of mechanistic models, is that you can borrow a modular. So and they're not 100% transferable. You have to think about how you transfer them, but they're quite transferable. So, for example, if active case finding works in Vietnam, which we know it does, and we know how much and why, you can say, well, that same program in another setting would work, and you can assume that it would work equally well, provided it's in equal coverage and so forth. So you certainly. And that's where you can project, what if we did that, what would that do? How much would that reduce the incidence and so forth?
Yeah, great.
Okay, cool.
Well, thanks very much. And you stuck to time really well. So thanks to all three of our speakers. Thanks for joining us. And these are recorded for people to listen to at a later date. So thanks again. Thanks, Emma.
Cheers. Thank you.